Perfect. Awesome. I see people joining us now. So, good afternoon, everyone. Welcome to our May ALS Learning Series with Dr. Kelly Gwathmey. I am going to quickly share my screen because I have a couple bits of housekeeping first. You will notice that you are muted and off camera, so just sit back and relax and enjoy the presentation today. It should take about an hour. Also, we are recording this, so it will be up on our website and our YouTube channel within the coming days. So in case you want to share this, talk with anybody, or you know somebody that wanted to come but couldn't, or you might have to hop off early, know that we are recording, so you won't miss anything. You'll also notice that the chat is disabled, but you can submit any questions through the Q&A box. So please direct all those questions there, and we'll have time at the end today to go through those. I am Anne Marie Doyle. I'm Director of Community Education here at the Les Turner ALS Foundation. And before we get started, I just want to make a personal thank you to our generous donors like the Gilbert and Jacqueline Fern Foundation and our industry partners, Mitsubishi Tanaba Pharma America, because without their support, we wouldn't be able to host these learning series. Now, we also know that a diagnosis with ALS can be really confusing and challenging, and you might not know where to turn to or, where to find information. Please visit our website at lesturnерals.org if you're interested in any past learning series that we've provided. Those are on our website. We also have in-depth information about ALS symptoms and care options through our guides. And we also have a number of My ALS decision tools, which are an online interactive decision support tool for different decisions that people living with ALS and their family members might want to think about. Things like genetic testing and whether or not a G-tube or nutrition support is right for you. And last but not least, we always want to promote our friends at the National ALS Registry and the CDC. This is really important, especially in these times right now. So if you are interested in learning about current research that's being done, or if you're interested in mapping out your diagnosis and maybe certain things that you might think have contributed to that diagnosis, like your where you live or your work experience or things like that, that can be done through the National ALS Registry. So please visit cdc.gov/ALS. And now it is without further ado, I'm so excited to introduce you all to Dr. Kelly Gwathmey. She is an associate professor of neurology at Virginia Commonwealth University in Richmond, Virginia. She joined VCU in 2019 and currently serves in the capacity of Neuromuscular Division Chair, Neuromuscular Medical Program Director, and EMG Laboratory Director. Her research areas of interest include environmental risks, diagnostic delay, and racial disparities. Welcome, Dr. Gwathmey. I will stop sharing my screen and I will kick it over to you.
Thank you so much for the kind invitation to be here. This is truly an honor to share our work. Let me get us in slideshow mode here. And thank you for all the attendees and the audience, and thank you for joining us for the next hour or so. So yes, I get to talk about a topic that I'm very passionate about, which is tackling the delay to ALS diagnosis. How can we do better? And then here we go. So we're going to describe the diagnostic delay in ALS. So what is it? What are the reasons for diagnostic delay in ALS? Go through physician factors, patient factors, racial factors, consequences of diagnostic delay, and potential solutions. So I always like to start off with a patient story. And so this story and the picture here is definitely provided from the patient, and he gave consent to share his story. And so in January 2023, this 55-year-old man developed painless right foot flopping with walking, and he had 3 falls. Then flash forward 3 months later, he was evaluated by orthopedics. He had an x-ray of his ankle, his foot, and his knee. And an MRI of the knee was ordered, presumably because they thought he had a pinched nerve at his knee that was causing the foot drop. They also ordered an EMG. And then only about 2 weeks later, the EMG was completed by a community physiatrist, so a physical medicine and rehab doctor. And that study was interpreted as a right sciatic injury versus L5 and S1 radiculopathy. And they recommended an MRI of the lumbar spine, but deferred to the referring provider. And then it wasn't until August that he sees a second orthopedist, because the first one sort of went off the grid. And at that time, he was saying, oh, I'm having worsening weakness, I'm falling. He purchased his own ankle foot orthotic. And in that note, if you go back and look at it, it says his pain is not the issue as much as the right foot drop and loss of motor function in the right leg. Then they referred him to physical therapy, and they ordered an MRI of the lumbar spine, which was done shortly thereafter and did demonstrate some stenosis or tightness around the nerve root at L5S1 level. And then a month later, he follows up with orthopedics. They prescribe him gabapentin, which is a nerve pain medication, which is interesting because the gentleman really didn't have much in the way of pain. And they referred him for an epidural steroid injection. So a shot in his back to hopefully calm down the inflammation around where that nerve root they thought was compressed. He went on 2 weeks later, had that injection, and then a month later goes to see a third orthopedic surgeon who then comments that the other foot has dropped. And they looked at his pictures and his exam and said he's a great candidate for a limited lumbar laminectomy. And then they even state in that note, should avoid fusion due to limited back pain. He goes on to have his laminectomy in December of 2023. And then first postoperative visit, he had disability paperwork filled out. Second postoperative visit, it states that he's had, quote, ups and downs in terms of recovery and needs more exercises and a new right ankle foot orthotic. And then come March 14th, third post-op visit, he has increased difficulty with walking and standing, and now they document he has signs of cervical myelopathy, which means that he has increased reflexes and increased tone, and he needs a STAT C-spine MRI, which was done the next day and did demonstrate some compression of the nerve roots coming out from the neck, but not the spinal cord itself. And at that point, they said neurology really needs to see him. And the patient, whom I know very well now, he took it on himself. He called around all the clinics in our city, and every practice had a 4 to 5 month wait. So he went to the emergency department and he was admitted to the hospital and had he had a brain MRI and then his spine re-imaged, and they called neurology, and they were at this outside hospital able to do an EMG or electrodiagnostic testing while he was hospitalized, and he was diagnosed with ALS during that hospitalization and started on Riluzole. He was then discharged to an inpatient rehab, acute inpatient rehab, for for just about a week, and then shortly thereafter came to see us for the first time in the VCU Health ALS clinic. So to summarize for this gentleman, he had 6 MRIs, 3 orthopedic surgeons, 2 neurologists, 2 EMGs, and an unnecessary back surgery. And that was a 15-month diagnostic delay before he finally found his way to us. So why is there a diagnostic delay issue in ALS? And the reason is, as many on this call know, ALS can be very challenging to recognize and diagnose early on. Such a heterogeneous presentation, right? So some patients will have speech and swallow difficulty initially. Some people will have hand weakness. Some people have foot drop. And then there's a lack of widely used high specificity diagnostic biomarkers. It's not as simple as going to your doctor and getting a blood test and a diagnosis. And then why do we even care? Why am I here talking to you all about this topic? The reason is we know that patient outcomes are improved when patients are diagnosed earlier and treatments are initiated earlier. What is the scope of the problem? So there are a lot of papers actually written on this topic, and the diagnostic delay is reported to be anywhere from 9 to 27 months. And though we often will say the average is 10 to 16 months, or 12 months is thrown around all the time in the literature and on websites and so on. So most patients in one study were already in a King stage 2 when diagnosed, which means 2 regions. So for example, their arms and their legs were affected at time of diagnosis, and that suggests about 40% of the disease had already elapsed. So I am going to show you some figures on tables from an amazing publication from our green journal, the Neurology Journal, in 2022, written by some of my good buddies, Ed Kazarskis, Hiroshi Mitsumoto, and Zach Simmons. And the title of this paper was Hastening the Diagnosis of ALS. And so in this first table, I'm going to show you the bottom line. It's very busy. But this is really a summary of different publications looking at diagnostic delay across different continents, different decades, and regardless of where you live or when the study was being conducted, pretty much every study shows a pretty significant diagnostic delay of at least 10 months on average. And then this is one of the figures that I use in a lot of my talks. This is from John Moran's paper in 2020 that really looks at the diagnostic journey for the patient. And so we start off on the left of the screen, seeing that the patient has their first symptoms, and then on average, it might take them 3 to 6 months before they seek medical attention. Or maybe they make an appointment sooner, but they have to wait until that appointment comes up. And that's when they go to see their first physician. And then from there, and it's usually a primary care doctor, 40% will get referred to a non-neurologist subspecialist. For example, if you have speech and swallowing problems, a lot of those patients go to see ear, nose, and throat or gastroenterology. They might also go see a spine surgeon, such as my patient, if they have sore foot drop or hand weakness. 60% do go to a neurologist first, and then from there, the neurologist helps get the formal diagnosis. But that total time, again, can be about 10 to 16 months. And then on average, a patient will see 3 to 4 different consultations prior to seeing an ALS specialist. So it's a very arduous diagnostic journey. So again, this is a figure from that Green Journal article in 2022, and it is an overwhelming figure, and I include it here to be overwhelming. And this is just simply, shows you all of the different paths that patients can take from symptom onset to eventually getting to that multidisciplinary clinic and getting access to medication and clinical trials. So we're just going to talk about that journey a little bit more. First, by site of onset. So bulbar onset, again, remember about 30% of our patients will have symptoms that start in their speech and swallow muscles. And that, resulting in what we call dysarthria and dysphagia. So speech and swallowing difficulty. So as you might imagine, if someone's having a hard time swallowing, then they're going to be seeking medical attention a little bit more urgently. And oftentimes their diagnostic workup's going to be a bit more accelerated. So their diagnostic delay is shorter compared to those who have limb onset. So it's about 7 to 10 months for bulbar onset compared to 10 to 22 for limb onset, which would be arm or leg. And then, as I already said, if you can't speak or you can't swallow, you tend to go to ear, nose, and throat or GI, or sometimes even go see a stroke neurologist. So what are the implications for having a delay to diagnosis in our bulbar onset patients? You can only imagine if someone's having a hard time swallowing, they're losing weight, and then they might need a feeding tube or benefit from a feeding tube, but there's delayed access to that, which could impact survival and quality of life. So in terms of limb onset, again, this is arm or leg onset. That's about 70% of our patients. We have some literature to support that patients might actually wait 3 to 5 months before they even go to see a doctor for hand weakness or leg weakness. And then beyond that, the key here is that the physician delay accounts for the rest of that significant delay in getting a diagnosis. And just like my patient, maybe they get sent over to physical therapy or they have, injections, back surgery, and so on. And so what are the implications here of a delay to diagnosis if you have arm or leg weakness? So 3 to 10% of our patients end up undergoing spine surgery, and up to 13% undergo inappropriate surgery generally. That might include carpal tunnel release, for example. And then lastly, a very small population of respiratory onset ALS. To me, this is a very tricky population because this diagnosis often gets missed. And the reason is their primary initial symptom is breathing difficulty. So they end up going to see cardiology and pulmonology. And these patients tend to have again, insidious onset of respiratory failure, difficulty breathing, especially with lying down. And they often will have kind of diffuse fasciculations, often in men, and they usually have a lot of weight loss as well. But they might have relatively preserved arm and leg strength, especially early on. And so there is delay because they don't look like a typical ALS patient. But these patients, more than anyone upfront, will need access to non-invasive ventilation like a BiPAP or a Trilogy device, which could help with survival and quality of life as well. And so by having a delay with them, they're not accessing that equipment that they need. All right, now we're going to talk about the physician's role in all of this. So I put the primary care provider here in the center of this picture, but it could just as easily be, a general neurologist as well. And so why are physicians missing or not thinking about a diagnosis of ALS? And some of it is a lack of awareness. Some of it, they make a misdiagnosis, and we'll talk about that in a moment. As I mentioned previously, they might refer to a non-neurologist first, or they might just be scared to make that diagnosis. So I have quoted this paper in a few different talks, but and then a lot of people think that this can't possibly be the case, but there is at least a publication out there that says that many primary care providers encounter only a single ALS patient during their entire career. And in one state, the decision to refer out to a specialist was delayed by 5 months. So meaning that primary care provider sort of held on to the patient, was doing their own workup for almost half a year before sending them out. 2/3 of primary care doctors did say that they felt like their training regarding ALS was low and expressed lack of knowledge regarding the clinical signs of the disease. Now, this publication actually was from 2006. So you might say to me, Dr. Gwathmey, there's no way that that's still the case. Everyone knows about ALS after the Ice Bucket Challenge. There's got to be some improvement. Unfortunately, not necessarily. So this publication from 2023, coming out of Ohio and the Cleveland Clinic Group, again, John Moran was involved in this. This was an email-based survey study that sent these surveys about ALS to Ohio-based primary care providers, including physicians and advanced practice providers. So advanced practice providers being physician's assistants and nurse practitioners. And so 77 doctors and primary care provider participants, of whom 30 were advanced practice providers. So 47 were doctors. All right, let's look at just a few figures from that paper. So when asked what signs and symptoms should trigger an ALS referral, I'll point out that in the dark green, these are the physicians, and in the blue, these are the advanced practice providers. And so not surprisingly, most providers knew muscle weakness, twitching, slurred speech, things like that should prompt you to think about ALS. What I think is concerning is that only 30% of physicians and 23% of advanced practice providers knew that emotional lability, like pseudobulbar affect, could be a symptom of ALS. And only 40% of both groups knew that cognitive or behavioral changes are part of ALS for many patients. How about where do we send patients with muscle weakness? And if you look at it, about a third of physicians said they would send to neuromuscular, and just over half of the advanced practice providers said they'd send to neuromuscular. And then if we ask these providers, why is there a diagnostic delay issue in ALS? I'm just going to point out the top 3. The first one is the patient's delay in seeking initial medical attention. Number two is the provider's not certain on the diagnosis. And the third is, well, it's taking too long to get my patients in with neurology or neuromuscular, and that's the holdup. So the highlights from this recent publication are that less than a fifth primary care providers in Ohio were confident with recognizing the signs and symptoms of ALS. Primary care providers report diagnostic uncertainty as one of the top reasons for ALS diagnostic delay. And then really a need to educate primary care providers and other non-neurologists, spine surgeons, ear, nose, and throat, and gastroenterologists, gatekeepers is needed. And then also we need to improve our access to neurologists. That really would help, right? No one wants to wait a year for a neurology appointment when they can't speak and can't swallow. So in an Irish study, almost a third of patients were initially misdiagnosed with something else. And then in this large study coming out of Mass General of just over 300 ALS patients, just over 50% were initially misdiagnosed with something other than ALS. And as I've already alluded to, for our bulbar onset patients that have speech and swallow difficulty, you can imagine they often get suspected of having a stroke or a tumor in their brainstem or multiple sclerosis or a condition called myasthenia gravis, which is an autoimmune nerve muscle junction disorder. Patients might even get diagnosed with ill-fitting dentures or vocal cord dysfunction. And for those patients who have arm and leg weakness, oftentimes they get misdiagnosed as having definitely spine disease, also peripheral neuropathy. And then looking at the issue where some of these patients are sent to a non-neurologist before a neurologist. So generally, if a patient is sent from the primary care provider to a neurologist, they have a faster time to diagnosis. So there was a study that showed that of only 16% of patients who were first assessed by a neurologist, 56% of those received an immediate diagnosis. And then in the UK, there was a small study looking at a fast track referrals program to neurologists, which shortened the diagnostic delay by 50%. And then the other thing is, I always joke, if you're an EMG, or again, that electrical test that we do that helps confirm the diagnosis, I joke, if you're an EMG, the answer is always to order an EMG. But in this situation, that really is the case. So if you go see a non-neurologist, only about 20% of patients end up getting an EMG ordered. But if you see a neurologist, 3/4 will get an EMG ordered. And again, that goes a long way to helping get these patients diagnosed quickly. All right. And then this is a very thought-provoking paper that was published at the very end of 2024 by my good friend and colleague, Dr. Suma Babu, and in association with the ALS, in collaboration with the ALS Association. And basically what they did here was they looked at a random representative sample of Medicare beneficiaries that had been diagnosed with ALS over the course of a decade, from 2011 to 2021. So it was just under 4,000 ALS patients. And they found that the average timeline between the first neurologist ambulatory visit to diagnosis was 16.5 months, or median was 11 months. That was shorter if you saw an ALS or neuromuscular provider first, so closer to 10 months, and then a non-neuromuscular neurologist would be 16.7 months. So really, it suggests that maybe non-neuromuscular neurologists are making up the bulk of the diagnostic delay in ALS. Now, I can tell you that's not necessarily the case in my neighborhood, where it seems to be the difficulty getting from the primary care doctor into neurology, not once you're in neurology getting a diagnosis. But I think this is very thought-provoking. All right, in terms of patient factors, and we don't have a lot of data on this, but very briefly, a patient's illness behavior is impacted by a lot of things, right? Your personality. Are you someone who avoids seeing doctors? How about psychological comorbidities, socioeconomic factors, access to healthcare, and age? All those things can sort of feed into whether or not you seek medical attention quickly or have a delayed kind of access of the medical system. And so again, as a result, some patients may go up to 6 months without actually seeing a doctor for a problem, be it hand weakness, leg weakness, speech or swallow difficulty. there is some literature to support that those with lower incomes might have a greater diagnostic delay, and those with cognitive impairment, difficulty thinking, memory concerns, may also have a greater diagnostic delay. And now we'll move quickly on to racial factors. So the question here is ALS diagnostic delay influenced at all by race? And so if you go back and look at the National ALS Registry, which we kind of started this talk talking about in 2016, about 75% of ALS cases are white, 6.5% are Black, and 13% are coded as unknown race. So clearly, our Black patients appear to be in a minority here when it comes to ALS. But few have looked at racial differences and disparities and the impact on the disease in ALS. The biggest study coming out of Emory, so in Atlanta, Georgia, and they found in thousands of patients that there was greater diagnostic delay, lower baseline functional score, lower baseline breathing scores in Black patients compared to their white patients over like 20 years. And then the Wake Forest group also looked at survival in their group, coming out of Winston-Salem, North Carolina, between Black patients and white patients. And initially, it looked like Black patients had a longer survival than white patients when the outcome was death. But if they corrected for the fact that a higher percentage of Black patients chose to have a tracheostomy and invasive ventilation, then the survival was equivalent between the two groups. And so in their patient population, 16% of Black patients chose to have a tracheostomy and invasive ventilation, whereas that was only in 5% of white patients. And that we've also presented our data on that from the VCU clinic and have found similar findings. So this is a recent publication that I assisted with in partnership with the CDC and the National ALS Registry, looking at, again, race and its influence on diagnostic delay. So looking at just over 4,200 registry participants, first I want to really emphasize that of those, 4,077 were white patients, 73 Black, and 92 other race. So we really don't have high numbers of Black and other race registrants in the registry, which is a problem right there. But looking at, and this is all self-reported, mean interval from first sign of weakness to ALS diagnosis for our Black patients, it was 24 months. For white patients, 16 months, and other race patients, about 16 months. So clearly statistically significant for longer for our Black patients than our white patients. And then for mean interval from speech change to ALS diagnosis, 17 months for our Black patients, 6 months for our white patients, and 14 8-point months for our other race patients. So they did not provide the statistical significance of this, but clearly there's a very big difference between those two groups there. So how did I and my team here at VCU in Richmond, Virginia, get interested in this problem? So we started to notice when I got here in 2019 that our Black patients were presenting with much more advanced disease. And that was resulting in delayed access to non-invasive ventilation, feeding tube placement, if they were even a candidate at all, and often inability to qualify for clinical trials. And so we retrospectively went back and looked at the baseline characteristics of our white and Black patients who came into the VCU ALS clinic from 2017 on to 2022. So where are we and why is it helpful that we can look at this? So in Richmond, Virginia, this is again the most recent population estimates going back to 2021. We're just about 225,000 in the city, and it's about half and half white population, Black population. We are. And then more representative, certainly than the city itself, is the Richmond metropolitan statistical area, which going back to 2015, which is when we had the most recent estimate, it was 1.3 million, and about 2/3 of the population being white and a third being Black. And that's the greater Richmond metropolitan statistical area. So this is a super busy slide, but I'll walk you through the important parts. So when we looked at our patient data, that we had a full kind of data set for, right? This is not representative of all the patients we saw, just the ones that we had a complete data set on. We analyzed 172 white patients and 33 Black patients for overall numbers of 205. And these two groups were evenly matched for age at diagnosis and distribution in terms of gender. And so just slightly more weighted towards being more common in men. And again, average age here for our white patients was 64.8 years and 61.3 for our Black patients. But what I really want to draw your attention to is if you look at the diagnostic delay in months, so that's from symptom onset to the date of diagnosis, it was just under 10 months for our white patients and 15.8 months for our Black patients. And that is a 64% increase in diagnostic delay for our Black patients. And that was clearly statistically significant. So we looked at a few other items. Everyone on this call is likely familiar with the ALS functional rating scale. And so, a perfect score, perfectly healthy, no deficits or changes in function at all would be a 48, right? And so if we looked at the average between our white patients at time of first visit, 39 in time of diagnosis, first visit to multidisciplinary clinic, 39 points for our white patients and just under 33 for our Black patients. And that too was very statistically significantly different, meaning, again, just to break it down, that our Black patients had worse function at time of initial presentation to our clinic. Forced vital capacity, right, is a measure of our diaphragmatic muscle strength. And 100%, we calculated out a percent predicted. So what is normal for you? We calculate that out. So 100 would be normal. And so for our white patients who came in, 80% of normal at first visit, 61.6% of our Black patients. So clearly statistically significantly lower muscle strength when it comes to the breathing muscles for our Black patients compared to our white patients. Now, this is an analysis that we just completed and actually just published, I think it was last month in Muscle and Nerve, looking at, okay, you're already diagnosed, going from diagnosis to specific clinical events like getting a wheelchair or getting referred to hospice or getting referred for communication device. And so when we looked at the data in a very similar data set, we found that our Black patients were actually more likely to get a wheelchair before they were even diagnosed than our white patients. And then beyond that, after diagnosis, there technically was no statistically significant difference between our white patients and Black patients in terms of time to wheelchair. But you see the p-value is sitting at 0.051. So certainly a trend towards it being longer for our Black patients. So non-invasive ventilation. So breathing equipment. So Black patients too were more likely to receive breathing equipment before or on the day they were diagnosed compared to our white patients. And then Black patients were more likely to receive breathing equipment sooner after diagnosis, again, suggesting more advanced disease at time of diagnosis. And then for a communication device, Black patients were more likely to be referred for communication evaluation, again, sooner after diagnosis, suggesting more advanced disease. So we did actually in that data look at hospice and it was not clearly different. So what are the consequences? Again, why are we talking about this? So mental health. This is a very concerning but very small study. So diagnostic delay has been demonstrated to be associated with depressive symptoms. So an Australian study from back in 2015 looked at 27 patients and they were with ALS, and they were administered both a psychiatric and medical questionnaire and a validated depression scale before they came into their first multidisciplinary clinic. And so in this small group of 27 patients, the average functional rating scale was 37.8 and diagnostic delay was 16 months, so on the longer end. And so when they looked at all the different variables that could account for this, the only thing that was resulting in or predicting depressive symptoms clearly was the diagnostic delay. So my team here is actually currently working on trying to study this in our patient population and correlating diagnostic delay with depression and anxiety as well to see if we can sort of replicate this in a larger patient population. How about the delay to multidisciplinary care? So likely everyone on this call is somewhat familiar with multidisciplinary clinics and why we follow our patients in multidisciplinary clinics, what's entailed in being followed in a multidisciplinary clinic. But the bottom line is, if you have a timely diagnosis, you get diagnosed promptly, through this multidisciplinary care model, you should have earlier access to disease-modifying therapies, rehabilitative care, nutritional support, respiratory support, and access to clinical trials. And all of this, again, is housed under that multidisciplinary care umbrella. So I could spend an entire hour just talking about the benefits of multidisciplinary care, but I'm not going to do that. But we know overall, and a lot of the references are at the bottom of the screen, that earlier access to multidisciplinary care can improve survival, access to medications, access to nutritional and respiratory support, mobility devices, and quality of life. And then also, by the way, you can save money. So there was a study that looked at how in the UK, how expedited referral to a multidisciplinary ALS clinic can save patients on average 2,000 euros. And so you actually, if you have streamlined care, you're going to save money, bottom line. All right, how about access to medications? So again, taking another figure from that great article published in 2022 in the Green Journal, just people might be familiar with this type of figure. So if we look at sort of in the y-axis, the number of viable motor nerves and function, and then in the x-axis, time. So the biological onset of ALS precedes the symptomatic onset, right? You know the disease doesn't start the day you have your first symptom. It actually starts before. And what happens between the biological onset and the symptom onset is that you are losing motor nerves, but your body's able to compensate, right? There's a sense that you can reinnervate and you can compensate. But at some point, the reinnervation or the compensation cannot keep up with the motor nerve cell death. And that mismatch results in the symptoms and the progression from there. And then here you see diagnosis in red, we have early diagnosis, in dark blue, we have late diagnosis. So as you are losing these functional motor units or motor nerves, if you have an early diagnosis and you're started treatment early, then you will have more viable, healthy motor nerves that you can essentially salvage, right? And then so you're going to have a more robust response to treatment than if you're diagnosed late, start treatment late, you have less viable motor nerves, and then so you're going to have worse outcomes. And then the worst outcome is if you don't start any treatment. All right, so this is a little bit complicated, but just to provide an example, this is a more recent publication from Muscle and Nerve looking at the impact of riluzole use and when you start it in relation to how well you do in terms of survival. So this data that was analyzed came out of something called the PROACT database, which you guys might be familiar with, but it's the Pooled Resource Open Access Clinical Trials and ALS database. And it's essentially taking all of the patients who are on the placebo arm in these different clinical trials and looking at them over time to sort of determine their natural history, if you will, or to analyze them as a different cohort that's not exposed to an investigational drug product, right? So what they did was the authors here said, okay, in this PROACT database, we don't have a clear date of prescribing or prescription for riluzole, but we can assume that once you're diagnosed, you get riluzole, and then you enroll in a clinical trial. Again, this is a clinical trial database. And so they use the time of enrollment as a surrogate for time of riluzole start. So if you look here, if you start riluzole 6 months after diagnosis, versus 30 months out of diagnosis, you see that the median survival decreases with time the longer out it goes from when the riluzole is started. So the sooner you start riluzole, the longer you live, the more delay in starting riluzole, the shorter amount of time you live, okay? So very important. So now let's pivot to the more optimistic part of this talk. So how can we find some potential solutions to this very significant problem? First, I just want to highlight the National Academies of Medicine report, which was recently published in 2024 called Living with ALS. It's a very lengty document with a lot of recommendations to our community. But in there, I just pulled out a couple of things. There is, highlighting as part of the action list that we need to educate primary care doctors and general neurologists about the symptoms of ALS and importance of early diagnosis. And then there is a specific recommendation in there as well about improving racial and ethnic equity in ALS care and the research system. So, just want to highlight that has been pulled out as very important priorities for our community. This is an outrageously complex and wordy table pulled from that 2022 Green Journal article again, but I'm just going to pull out the important things. These are the challenges and recommendations for hastening the diagnosis of ALS. Number one, let's educate. We're going to educate other providers on the signs and symptoms of ALS. We're going to educate patients whenever we can on the importance of getting started on treatment early. Number three, we need to find better diagnostics. I think everyone on this call would agree with that. And how are we going to do that? Number four, we need to improve access. So once you have a diagnosis of ALS or a tentative diagnosis of ALS, you need to be able to be seen quickly by an ALS specialist. And then five, we need to spread the word. We really need to make the entire community know this is a problem, this is a priority, this is a problem we really need to tackle. So how can we do that? There are lots of different intervention strategies. So how about educating, the patients and the providers? So in my community, we spend a lot of time with community outreach and education. I'm on the news all the time. We're talking about our program. We're talking about ALS and the signs and symptoms. And then what if we could also, and we talk about this a lot, but I'm not aware that anyone's yet to do this, what if we can embed in our electronic medical record decision support software and diagnostic guidelines? So what if you're seeing a patient in clinic and all of a sudden you put in all their symptoms, an alert goes up that says, have you considered ALS for this patient? Wouldn't that be incredibly helpful? Really want to highlight the Think ALS tool that was developed by the ALS Association with the Time to Diagnosis Working Group. This is free. It's in the public domain. In my clinic and in my community, we use it routinely. It was designed to really with the target audience being the community neurologists. Now, I will admit that we use this targeting the general practitioner in my community. But essentially, it's check boxes, right? Does this patient have pain with progressive weakness? Yes or no. Slurred speech? Yes. Difficulty swallowing? Yes. Do they have supportive, features like a family history of ALS or progressive unintentional weight loss? Well, if they have a lot of pain or a lot of numbness, that would go against ALS. So you can kind of work through this algorithm. And if it looks like they do have ALS, then they absolutely should be referred urgently to the closest ALS clinic for evaluation. And then there is the website, but you can easily Google it, Think ALS tool. The Europeans have a similar tool called the Red Flag Diagnosis tool. It's a little bit more involved, but that is free and in the public domain as well. How about improved diagnostics? So many of you are probably familiar with the fact that we are constantly trying to come up with better diagnostic criteria so we can diagnose patients sooner in their disease. So historically, we've been using the revised ALS criteria. The Gold Coast criteria with Jeremy Scheffner was the lead author, was published in 2020. And I will keep this very brief for this audience. But essentially, what it's doing is saying, if you have mixed upper and lower motor neuron signs, so like spasticity, hyperreflexia, but also atrophy, fasciculations in one body region, so like say the arm or say the leg, then that should be enough to say you have ALS by Gold Coast criteria. Or if you have pure lower motor neuron signs, so again, atrophy, fasciculations in two body regions, then that all of a sudden you can say that's ALS. In ALS criteria, you would not say that. So again, just looking at the differences between these two diagnostic criteria, it does sort of favor giving a diagnosis to many ALS patients sooner if you use the Gold Coast criteria. Now, there was actually a study that showed this that was published not too long ago, about 3 years ago or so, I think. And this came out of the Netherlands and Belgium, and they looked at almost 6,000 ALS patients. And if they applied the Gold Coast criteria, they were able to diagnose an additional 10% of patients, or 600, using Gold Coast in comparison to the Ellis criteria. So really, you're just capturing more people sooner on. All right, diagnostic biomarkers. I'm sure you guys have had many a talk about this, but just briefly, if we can develop, identify, and make commercially available diagnostic biomarkers, then we're going to be in much better shape. Like I said at the beginning of this talk, we all wish we had a blood test that someone could just send and make a diagnosis. It would make it a lot easier. Right now, a lot of us are using neurofilament light chain, both clinically and of course in research arenas as well. But if it's really elevated, then that would strongly support ALS, though it is non-specific. So you can see it in other types of neuropathy, for example. But if it's really elevated, it helps differentiate ALS from other conditions. And as we know from our SOD1 literature, it can increase prior to time of diagnosis. All right, improving access. So how do we get to the patients to where they need to go? So again, taking from that time to diagnosis working group publication from December 2024, the one that shows not only the Think ALS tool for the first time in the literature, but also talks about that Medicare, those beneficiaries and how the non-neuromuscular neurologists are the problem. So from that same publication, the working group states that anyone who's referred for ALS, you need to write on the referral ALS or clinically suspected ALS and mark it as urgent and send that referral to the nearest ALS multidisciplinary center. So being on the receiving end of all the referrals for my division and for the ALS clinic, of course, I can honestly tell you that we get ourselves in trouble when a general neurologist an hour away sends a referral and it just says weakness. And then if you really read through it, you can tell that maybe you're worried about ALS, or maybe they should be worried about ALS, but they did not put it on the referral that way. And so that patient just gets added into the same queue as everybody else. Whereas if someone comes over and it says, I'm worried they have ALS, we expedite that, right? So what have we been doing in the VCU clinic to really try and get at this problem, this access problem? So starting in September 2022, we started piloting a monthly rapid access clinic, which I call the RAC, for any patient in my region suspected to have ALS. We took on a big advertising campaign to the community, academic healthcare providers. We have webinars, email, print communication. The idea here is that any patient referred over to us with possible or suspected ALS is seen within 4 weeks of referral with a same-day EMG and a smaller multidisciplinary clinic. And here at VCU, currently that includes nursing, social work, respiratory therapist, dietitian, occupational therapist. So this is a completely separate clinic in my big ALS multidisciplinary clinic that's every Tuesday. This is on the left, you just see the kind of title slide of our webinar. On the right is our brochure. I know you can't read that, but it essentially says, what is ALS? What is the Rapid Access ALS program? How do you refer your patient? There's a hotline number. So you just call and you can, if you're a patient, you can refer yourself or the provider can call. And so my nurse navigator, Michelle Gebhardt, who's a saint, she is getting multiple calls per week into this program from our state and now surrounding states as well. So we wanted to sort of analyze whether or not this is working. Again, it started in September 2022. So we looked at demographics and symptom severity for patients diagnosed in this rapid access clinic model and those diagnosed, what I'll say is the traditional model, which is you see a community-based neuromuscular doctor, you get an EMG, you get all the MRIs, you're told you have ALS, you're started on riluzole, and you're sent directly into our multidisciplinary clinic. And so in these two groups, the traditional multidisciplinary group of patients and those that were diagnosed through the rapid access clinical model, we looked at time from symptom onset until they came into clinic the first time. They were referred, they came into clinic the first time, and they were actually diagnosed for the diagnostic delay. And again, super busy slide with lots of data. And this data cut was, about a year ago now. But we looked at the differences. If you see here, the patients living with ALS that were diagnosed in the rapid access clinic, that was 33. And those who were that were seen, in the multidisciplinary clinic, but diagnosed outside these external PALs were 26. And we looked at differences in their functional rating scores. So 38 in the rapid access clinic patients and 31.3 in the traditional model external PALs. So again, this is great news because it means that our rapid access clinic patients are coming in with less severe disease because they did not have such a circuitous route to get to us, right? They didn't go through the traditional general neurologist, EMG imaging. They got, their timeline was sped up. So they had less severe disease. We saw that as well on their vital capacity, their breathing numbers, 77.8% of normal in our rapid access population compared to just under 60% in our traditional model patients. And then they were evenly matched across age, race, gender, and onset location. I'm not going to show you all of that. So when I talk to people about the rapid access clinical model, people will say, my colleagues, that, oh gosh, I don't want to see a ton of patients who don't have ALS. That's just a waste of time. And so first I'll tell you that I triage every single referral that comes in to make sure that it's legitimate. If you look at the breakdown of our patient population that was seen in the rapid access clinic, 47% ended up having ALS. So that's a diagnostic yield of nearly 50%. That's really good. Now, if the orange is 11% of non-ALS motor neuron disease, who are these patients? These ended up being primary lateral sclerosis, progressive bulbar palsy, non-ALS motor neuron diseases. And then 42% of the patients had neuromuscular disorder. So what was that? Inflammatory muscle disease, inflammatory nerve disease, myasthenia gravis, that autoimmune nerve muscle junction disorder. These patients were sick. They needed a doctor urgently as well. And so it was still good that they came in, they got a diagnosis, they got the help they needed, and then they were triaged out of the ALS clinical model into our more traditional neuromuscular clinics. All right, last few slides here. So if we look at, again, the distribution between our rapid access patients and our external patients that were seen for the first time in the multidisciplinary clinic, and we're looking from symptom onset to time to referral. First, we've got 9 months for the rapid access and 12.7 months for those who were referred into the multidisciplinary clinic. So that was statistically significantly shorter for those who went into the rapid access clinic. From symptom onset to initial clinic visit, similar trends, statistically significant, and symptom onset to diagnosis. So this is the diagnostic delay question. So this was about 2 months difference. So we got our patients diagnosed through the rapid access clinic 2 months faster than those who were seen in the multidisciplinary clinic the first time and diagnosed outside. So again, 2 months is a long time, right? When the average diagnostic delay is about 12 months. This was not statistically significant, though. I think that's likely due to the low numbers in both groups, but again, very exciting trends. The average time from referral to the first rapid access visit was just under 30 days. So you might say to me, well, Dr. Gwathmey, you're promising everyone they get to be seen within 4 weeks. Why is the average close to 4 weeks? So this is part of the problem with this clinical model as it currently stands. If you only have one rapid access clinic a month, then they can't come that time. Then they're put the next month, and then that's almost a 2-month, right, wait, or somewhere between 4 to 8 weeks. And then the time from rapid access clinic visit to diagnosis was anywhere from about, on average, 4 days plus or minus 14 days of additional testing needed to be done, like labs, imaging, and so on. So interestingly, those who were seen in the rapid access clinic had no racial differences in diagnostic delay. Now, numbers are super small, but that's really important and meaningful to us because we specifically partially set up this program to address these racial disparities in my community. And we have been extremely thoughtful in terms of who we educate about the signs and symptoms of ALS, including a lot of providers in our more minority kind of populations and areas of town. And then, right. So based off this preliminary data, the rapid access clinical model did improve diagnostic delay in our Black patients, statistically significant, but so far not in our white ALS patients in this study so far. And with that, before I get to our take-home points, I do want to announce very proudly that the ALS Association has funded VCU we received a Hoffman Clinical Capacity Grant to expand the Rapid Access Clinic. And so this is not to expand my normal ALS clinic. This is to expand the Rapid Access Clinic with the idea that over the next 3 years, my program manager, who is 100%, kind of belongs to me in our ALS clinic, is going to go out and educate 1/3 of the state each year. And then every year we increase the number of clinics by one per month. So by the end of 3 years, our goal is to have educated primary care providers, general neurologists, and others across the entire Commonwealth of Virginia and have a weekly rapid access clinic to take in these patients and make a diagnosis with the plan that we will then send them back to their local ALS clinics. And so if you are coming from, if anyone knows Virginia, Roanoke, which is about 3 hours west of here, I diagnose you, your closest clinic is really going to be either the University of Virginia in Charlottesville or the smaller ALS clinic in Roanoke. So they'll go back closer to home. They're not expected to always travel to come see me, but we're really just trying to address the diagnostic delay concerns. So with that, the take-home points: ALS diagnostic delay is influenced by numerous physician, and patient-related factors. And it can result in worse outcomes, increased costs, poor mental health, unnecessary surgery, shorter survival. And so to address this problem, we need to educate providers and patients, improve access to ALS specialists, perhaps through a rapid access model, and improve diagnostics, right? Absolutely. And then that's our outline one last time. And this is a picture of us from the 10-year anniversary of the Ice Bucket Challenge outside of my clinic. This is a number of my clinical team, including some of my research coordinators. So just wanted to say thank you so much for your attention. I'm happy to take any questions you might have.
Dr. Gwathmey, thank you so much. Oh my goodness. You've got my brain just going in so many different directions. First of all, congrats on the
Thank
Rapid
you.
Access Clinic. I can remember you talking about that maybe at Neil's like a couple years ago. So to see it like actually evolve from this idea to being this tangible thing that you're putting into place and now funded for the next 3 years is so exciting for you guys. We're so excited to hear that. So we had one question come in, and this is related to kind of what you were talking about with that diagnostic delay, right? So by the time somebody might be able to get into a multidisciplinary clinic, they may not be able to participate in clinical trials, like experimental clinical trials versus like an observational or a natural history study. Um, Obviously, we want to improve that diagnostic delay, right? So we can get more people involved in those experimental treatments. But
Right.
is there any thought on changing the criteria beyond that, like first year of onset? I feel like that's a very common exclusion criteria.
Right. You mean for the clinical trials
Yeah.
specifically in terms of the inclusion exclusion criteria? I mean, I, I will say that my observation is a lot of clinical trials are actually moving towards less time from symptom onset to enrollment, right? Like Healy as an
Yeah.
example, going from 3 years to 2 years. Some of the other trials that are starting up are going to be 18 months, 24 months from symptom onset, which makes it even more important that we get patients diagnosed sooner. So I just want to emphasize something that essentially you pointed out is that so many of our clinical trial participants are Caucasian, non-Hispanic white patients. And we all need to work harder to get some of our minority patients into clinical trials. It's extremely important to provide access to all patients to have clinical trial, experience if they're able to qualify, and also just to understand how these drugs work in other non-Hispanic Caucasian populations, right? So if, the diagnostic delay is even greater for, say, our Black patients or Hispanic patients, perhaps, then they are already at a disadvantage in terms of coming in and getting in a clinical trial. And so a few years ago, I presented a case at NEALS of related to this concern. And I had this beautiful, wonderful mid-30-year-old Black lady who came in with ALS, who had been misdiagnosed as having a stroke and all of this. And she was holding a sign that said, "Please put me in a clinical trial." And like she came in with a vital capacity of like just over 50%,
Oh
so
gosh,
it
yeah,
was really a struggle to get her into a study very quickly. But I mean, it just goes to show we need to all work harder as a
yeah,
community to get everybody diagnosed sooner so they can access interventional trials, which is really what we're talking about. Yeah.
yeah. Um, Thinking about your idea around kind of putting something in an electronic healthcare record. I know there's some emerging literature from like behavioral economics and this idea of like nudging, which kind of looks at the subtle reasons as to why somebody might make a decision. Do you know if anybody is kind of looking at that with that idea of putting something in a medical record where I'm documenting the person who's come in symptoms and maybe something pops up to nudge me, or like you had said, like, have you thought about
Yeah.
ALS? Um, do you know if anybody is actually looking at that? I think that's really an interesting area that could be studied.
I totally agree
Yeah,
with you. So I will say that I'm not aware that any health system has that in place currently. I am now part of the ALS Association Time to Diagnosis Working Group, and we are talking about trying to build out in Epic, which is the most
yeah.
commonly used electronic medical record, some sort of code and program to pilot it at a single center to see if some sort of decision tool would work being embedded. I mean, just kind of borrowing from a different disease, you can do this, right? So at VCU, we built out some logic so that when my myasthenia gravis patients are prescribed medications they can't take, alerts go off and say, "Stop, do you
Like,
really want to
don't do
do
this.
this?" Right? So you can certainly build that
Mhm.
logic in. It's just, will it actually work? Will it actually, will it be used? Will it be disregarded? Will it result in shorter diagnostic delay and, all of those things? But yes, I mean, we are just starting to work on that kind of on a very small scale.
Okay, two more questions, and I want to be mindful of everybody's time. Would AI be a good source for incorporating into the medical record? So, kind of building off of this idea, to help with a symptom checklist.
Yes, yes. And that's been discussed as well, that if we can use AI logic and bake that in, that certainly that could help significantly.
Yeah.
Yes.
And then last question that came through, is there a concern about people receiving an incorrect or a premature diagnosis?
Now that's a
Yeah.
wonderful, wonderful, wonderful question. And I stay up late at night worried about this, right? So because I, as someone who sees a ton of ALS and manages a ton of patients, like I'm worried too that I could be too aggressive and like go the other direction and tell someone, no, you might have ALS when it turns out to be something else. And so we're really careful about that. I try not to say anything unless I'm extremely confident it's in that direction. But I always also err on the side of being honest with my
Yeah.
patients and transparent. And I'll say, I'm worried this is what we're dealing with, but let's do some other testing. Let's repeat your EMG in 3 months. Let's just keep following you. So there have been several patients that we will see every 3 months or even monthly
Yeah.
in the rapid access clinic while we kind of sort it out and see which way it evolves, and so just being open, transparent, and communicative
Mhm.
goes a very long way always.
Yeah, I think that's such a great model. And I know as if I were a patient or a family member, like that's something, just let me know. Like, let me know your thought process and we'll tackle this together. And a term I always used when I was doing swallow studies was let's be cautiously optimistic, right? And just continue to reassess. Um, Dr. Gwathmey, thank you so much for your time today. I could talk to you for hours.
Thank
But I
you.
won't. Everybody on the call, thank you so much for your time today. Just a quick plug, our next learning series is going to be June, Thursday the 26th. We're doing something new. We're going to be joining the Healy platform Q&A. So that registration will be up on our website in the next couple days, along with this recording. In the meantime, happy end of ALS Awareness Month as we're going through the rest of the month. And we look forward to seeing everybody in June. Thank you all for your time today.
Thank you so much. Take care, everyone.